Charlie, why don't you tell me a little bit about your first encounter with a community health center?
Well, I was working for the New England College of Optometry and was given the responsibility to develop new clinical affiliations. And I was introduced to Mr. Jim Hooley at the Dorchester House Multi-Service Center. And at that time, the college had what I would consider an informal affiliation, but I wanted to formalize that particular arrangement, which we did. And then from that, Bob Morgan from Demick contacted me, Mel Scoville and Tris Blake from South End, and that was really the beginning of a development of a network of affiliations for optometry in Boston. Our objective initially was to provide new clinical training opportunities for our students, but we soon realized that we could also employ a commitment to community service, and which has continued, I understand, to this day.
What was it like, though, in those early days? What kind of facilities did you have? Who did the work for you? All those kinds of issues.
Well, the College of Optometry had only one clinic, and it was in Kenmore Square. And the students saw other college students there, and it wasn't a very challenging patient population. So that was another reason I felt that dealing with the inner city health centers might be helpful in terms of clinical training, because we knew that the demographics suggested that many of the individuals would have more serious eye and vision problems. It was a very welcome experience for me. People at the health centers were very cordial and very inquisitive. And I remember my first encounter with Bob Morgan at Demick. It was like I was being interrogated. He wanted to know from step one what the basic concept was and how we were going to do all of this. And he said, well, how about ophthalmological services? And I said, yes, that's important. So he arranged for me to meet with David Miller, who was over at the Beth Israel Hospital and a Harvard faculty member. And from that, we developed the first ever relationship between optometry and ophthalmology working together in this happened to be a community health center. And that particular arrangement or relationship continues in the health centers today in Boston, but also has been expanded first in the Philadelphia area with Hahnemann University, and then in Chicago with the University of Chicago's Department of Ophthalmology and Visual Science.
Charlie, when you went into Demick, what kind of facilities did they provide for you?
Demick had nice space, but really no facilities that were conducive to eye care. So Bob Morgan convinced his board to provide the funds to do some renovations, and also I was able to successfully negotiate some equipment purchases that fit in their budget. So we ended up with a very nice eye care center. South End was, as I recall, was functioning in the basement of a school, and it was sort of a makeshift exam lane, but needless to say, it functioned. And Dorchester, in its early days, I believe, was functioning in a townhouse of some sort.
Well, no, it was a six-decker.
Six-decker.
And I think they gave you the conference room.
Okay, yeah, but over the years, of course, that's turned into a premier facility. Yeah.
Who were some of the early optometrists who worked at the health centers?
Well, as I recall, it was Jerry Selvin. He's still with the New England College. Neil and Jeff Nyman. They're currently at the Pennsylvania College, but were instrumental. A fellow named Ralph Lavoie, Barry Baresi, who's now gone on to be the executive director of the American Optometric Association. They were all key individuals and somewhat unique with a true commitment to community service, not just education.
And in order to, you mentioned that Bob Morgan, went to his board. Did you have experience yourself going to the community health?
I was always, as I recall, just about every community health center invited me to meet with the board.
Yeah.
There was a reluctance to have students involved, and I think this goes back to many of the people in the inner cities' experiences with emergency rooms in hospitals were not very good, and they thought that this might be a repeat of that. Also, the medical people in these health centers were not terribly familiar with optometry, and we had to convince them at a very fundamental level that optometrists had a role to play in a multidisciplinary health environment.
Who were some of the key people that you worked with? You mentioned, Bob Morgan and Mel Scoville, Tris Blake, and Jim Hooley. Who else did you work with that were really important to?
Well, the president of the college at that time, Bill Baldwin, realized that it was important for optometry and optometric education to move into real healthcare settings. And he encouraged me and supported me in terms of developing the initial affiliations that have now obviously grown significantly into an excellent network of not only teaching opportunities, but a national model of community service.
The health centers certainly were groundbreaking in terms of, matter of fact, we have the first health center in the country here in Boston, Columbia Point. But this was also groundbreaking in terms of a college of optometry working with community-based organizations.
Absolutely. This was the first ever optometry college working with a community health center. And it was the first ever where an optometry college worked with ophthalmology in a community health center. So we had two very progressive moves in the late 60s, early 70s.
This in Boston, this really took off after the initial. Can you kind of describe how it kind of?
Starting with Dorchester, and we had also an affiliation with a government facility, the Public Health Service Hospital in Brighton. And then, of course, as I mentioned before, we went to South End, Demick. And then I started getting calls from all sorts of facilities in Boston, not necessarily interested in the same model, but interested in optometry. The Harvard Community Health Plan, MIT's Student and Employee Health Service. Far away as the University of Massachusetts contacted me. So it was not just community health centers, which obviously is very important, but it was the beginning of a whole movement to include optometry in mainstream health care.
It's pretty interesting how it started that way.
I mean, I was flabbergasted by the people that would call me. Yeah.
Was the kind of political environment difficult for you to get through this?
I didn't really have any concerns about its success or failure. I guess when you're younger, you have tremendous confidence in what you're doing. I did get a lot of criticism from my colleagues, not at the College of Optometry, not at the New England College, but nationally, for such an unusual clinical training program. They felt that the only way you could possibly train an optometry student was in a single-purpose, campus-based facility. And of course, that's totally contrary to what really should happen if optometry is going to maintain a position of leadership in healthcare.
So how did you deal with that? How did you deal with your colleagues?
I just kept going. I tried to explain to them what we were doing. I explained that at our Kenmore Square clinic that the college operated, they were seeing young college students that may need contact lenses or myopic correction, but they were not seeing the types of patients that they ultimately would see in their practice, and that had to change. And most of the other schools throughout the country had the same problem. Fortunately, with community health centers here and federal affiliations in VA and the VA centers and military facilities, they were able also to see some more challenging patients.
And also, the eye care services, these facilities then and today, really provided more affordable services as well. Is that true?
For the patients?
Yeah, for the patients.
Oh, absolutely. Yeah. The campus-based facilities were often dependent on private pay patients and whatnot, and would not do very well with the medical assistance patients, etc. So this initiative fulfilled so many things simultaneously, not only quality clinical education, but, as I said, ingraining a commitment to community service in our students, and also the feeling of providing services that are really needed in the community.
What were some of the significant things that happened during the development of these things, as best you can remember?
Well, what was interesting to me was the initial relationship between optometry and ophthalmology. At the Demick Community Health Center, we had David Miller and his colleagues. At South End, we had Mark Richmond, and then eventually Andre Gomina joined the staff. But initially there was, since none of the ophthalmologists had really a lot of experience in dealing with optometry, there was a lot of caution and oversight that was taking place between the ophthalmologists and the optometrists. And eventually the confidence was developed, and that was eased over a period of time. But that was a very important aspect of the development of that relationship. But as I mentioned earlier, the health center administrators, Bob Morgan, and I believe his assistant was Mr. Johnson, were just wonderful to deal with, and as was Jim Hooley and Mel Scoville. Mel came out of the business world, so he had a business perspective on this, and made sure that we constructed these things so that it made sense from a business point of view, which was helpful to me.
Yeah. What do you think the impact has been on students as well as the communities that basically got these services initially?
It's been significant, not just here in Boston, but nationally. The New England College of Optometry, the New England Eye Institute are now considered national models for the training of optometry students in the community. Also, I think it's influenced a number of individuals who normally would have probably gone into traditional optometric practice, but have become interested in community health and community health care policy. As I mentioned earlier, Barry Baresi, who grew up in this system, has gone on to one of the highest offices in our profession in setting a national health policy.
Yeah. And what about the people in the communities that got these services?
Well, initially, the reception was very positive. The negative was we had some opposition from some of the ophthalmologists and unfortunately our own profession who felt that we were encroaching in areas that were rightfully theirs. However, we eventually demonstrated that nearly all of the people that we were seeing in the health centers did not have access to health care previously to our coming there. And I think we eventually alleviated that particular set of problems.
I do remember the, the interaction with some of the local optometrists. How did you handle that?
Well, that was, I have to give credit to the president of the college. He set up a committee of optometrists, private practicing optometrists, and a few of us, and we met regularly. And I think it was a process of diffusing the issue more than it was solving it. We just met and discussed it. But I also produced some data that showed that these patients were not previously being seen by private optometrists, but were coming into the health centers for the first time.
Do you think the work you did in those years, this is almost 40 years ago when you started this, right?
Yeah. Oh my goodness.
Do you think that work has had an impact upon how optometrists are viewed today, and also how optometry provides services to the general population?
Absolutely. Optometry students were traditionally trained in their own, quote, teaching clinics like we had at Kenmore Square. It was rare for them to be interjected into a medical community or medical facility or healthcare facility. And this really facilitated inclusion of optometry as a partner in delivering health care.
Now, a lot of the colleges still use the old model, though, right? They have a central facility and so forth. Why haven't they embraced this model? Or have they?
They would like to embrace it. We were fortunate here in New England. I guess I was lucky, but we were fortunate to have individuals who were committed to developing the relationships and to nurturing them over a period of time. I don't think the commitment is there yet in the other schools and colleges, and they stick to the old way of providing teaching opportunities and care in their campus-based clinics. But from my own experience, I know that nearly all of them would love to emulate the New England Eye Institute's system.
You've been active now here in the New England College. You're on the board and active with the New England Eye Institute, which oversees the clinical system. What's your comparison between when you first started the system, 40 years ago and today? How would you view it?
Well, I would use the word far more sophisticated now. The overall management is far more sophisticated. I hate to use this expression, flying by the seat of my pants, but I was. Now it's a very refined, well thought out management structure. Student placements are considered very carefully, and always the commitment to community service is in front. I'm not too sure that was there initially because the motivation was to provide student clinical opportunities, but it has grown and has become an inherent part of the mission of the New England Eye Institute and the college.
And I think now there are 14 community health centers involved with the college and with New England Eye Institute, and the facilities are quite different, right?
Oh, absolutely. Yeah. I'm very impressed with the number and the quality of the facilities, and also the fact that other health centers are also seeking affiliations with the New England Eye Institute and the New England College.
One of the other things that I've heard is that the college and NEI are interested in actually exposing students even more to multidisciplinary approaches to providing care for people. Is that That's not quite as developed as it needs to be at this point.
No, but there are initiatives underway to increase the number of affiliations so that third year and possibly even second year students in sort of an observation capacity could participate in community health.
Yeah, and how important is that?
It's extremely important that students are introduced into clinical activity as soon as possible. Optometry, like medicine, is a clinical discipline, and ultimately what we want to produce or graduate is a competent clinician.
Charlie, what are you most proud of in terms of your early work here in Boston?
I'm proud that a initiative that was sort of ill-formed initially has grown into a very sophisticated system, and it's lasted. Not just lasted, it's improved and been enhanced over the years. And I think if we count back, it may be close to 40 years.
Yeah. It's amazing, isn't it?
It's amazing. Time goes by quickly.
Well, historically seems to be, stress, tension between kind of the service mission and the academic or the teaching mission. And has that been an issue here as well when you first started and also recently? Initially,
when I first started, it was not a large issue, only because the president supported the initiative and that we were in need of student teaching encounters. So this was welcome as a very positive step, and there was not, quote, this gentle antagonism between the academic people and the clinical people. I think over the years, unfortunately, we've acquired some of the same problems that medicine has between the two bodies, the clinicians and the academicians. But it's never going to go away completely, because the individuals who are providing care and teaching students and residents in a clinical setting have a whole different approach to their mission, to their responsibilities, than do the researchers and lecturers in the classroom.
So you even though this has been an issue, you don't think this is an issue that's very significant, or?
It's not unique to the New England College of Optometry or the New England Eye Institute, but it's the kind of thing that requires constant communication between the two groups and exchange of information, so that there aren't misconceptions as to what's going on between the two very separate teaching approaches.
It's interesting that I think that if you were to poll the health centers that provide eye care services, they would now view eye care as an extremely important service to provide for their community. Whereas when you first started, basically they really probably didn't think about it.
I don't believe any of them really had eye services on site. They may have had some,
or even contemplated.
Or even contemplated. I always thought it was strange. They had dental services, but no eye services, and certainly dental services are important, but certainly eye care is also very important.
Provider sites, I think, have really embraced this and view this as really important.
Well, it seems now that it's considered, a requirement for the health centers to have eye services, both optometric and ophthalmological consultation. As I recall, the statistics are not very good nationally, with only about 17% of the health centers in the country having eye services, whereas Boston, I guess, is nearly getting to the point where all of them have. So again, it's set a national trend, hopefully, for other community health facilities throughout the country.
What is being done, or what can be done to actually increase that percentage from 17% nationally in community health centers?
Well, the New England Eye Institute, the New England College, is in a unique position to provide national leadership in this area. And already we have done some of that. Dr. Roger Wilson from the New England Eye Institute is considered a national expert by his colleagues and by the professional association, the American Optometric Association. I believe that this college and the New England Eye Institute have a responsibility to advise individuals or organizations that are interested in affiliations, interested in optometry, interested in student placements, take a proactive role in doing that. And I believe we have some preliminary ideas as to how we can approach that particular initiative.
So you think this will be a future activity for the college and for the New England Eye Institute?
I view a college and its subsidiary, the New England Eye Institute, has a commitment and a responsibility to advocate community eye care services.
What do you, if you were to, talk to students who graduated from New England College or students who are here now, what do you think they would say about this network of community-based services?
I think without question you would get very positive comments about being in the health centers, the challenging patients they see, and the fact that they are able to interact with other healthcare disciplines in the community centers.
About 5 or 6 years ago, the college actually formalized a subsidiary to focus on the clinical education program in the community, and set up New England Eye Institute and invited you to be on the board and
right.
other people, and maybe you might want to talk a little bit about
Well,
that.
it was a very important move because it provided opportunities that don't exist for an educational institution necessarily. Legal separation and formation of two separate boards provided an opportunity to recruit board members with different skill sets than the traditional board member on a college. More healthcare executives, more medically oriented individuals than the college board would traditionally have. It also provided us with an opportunity, which we are demonstrating quite nicely now, ability to raise funds from foundations for patient care and community service activities that these foundations would not normally support educational institutions. It also permitted a more focused attention to the issues of a healthcare system versus an educational institution. And that is often not stressed in other colleges of optometry, where education is paramount in the delivery of health services, which are critical to a clinical educational program, do not get the attention or focus they deserve.
And who were some of the people who were invited to be on this new NEI board, and why were they chosen?
Well, of course, Jim Hooley, years of experience in community health and years of experience with optometry. We had Jim Hunt, of course. I think everyone knows Jim, a leader not only in the Boston area, but considered a national expert on community health. We also have a dentist, a physician. They bring interesting perspectives, as well as, of course, representatives from the college. The college president brings her perspective on the importance of the educational mission. And then we have a lawyer, Herb Gleason, a very influential individual in the Boston area, with keen insights and analytical skills. And we also have financial people and an ophthalmologist. I think that brings a nice balance to to a very, very strong, and I might add, very dedicated.
The public health role that these programs have played.
Well, the role is multifaceted. On one hand, again, it will continue to provide clinical teaching opportunities for students, ingrain a spirit of community service in the graduates of optometry, introduce individuals to community policy, community health, who will later go on to have significant roles either in the private sector or the federal government, as I did. From my experience in Boston, I was appointed to the Department of Veterans Affairs, and I had a sense of the importance of optometry in a overall large healthcare system.
So did your experience in Boston, how did that kind of help you with your future jobs and your career and also your professional contribution?
It's my legacy. I was fortunate to have some very nice positions here, of course, at the New England Eye Institute College of Optometry. I went on to the Pennsylvania College of Optometry and directed a large centrally based clinical program. But my experience here in Boston was known by officials in Washington, and I was recruited to head up the National Eye Care Program for the Department of Veterans Affairs. And from there, I went to be the president of the Illinois College of Optometry. But I can say this with all certainty that people remember me not so much for the latter positions, but when I was a young gentleman, a young fellow here in Boston.
Yeah. And why did you try to actually, kind of model this program in these other places like in Pennsylvania and Illinois?
Well, in particular, the relationship between optometry and ophthalmology. I definitely built on that relationship in Philadelphia, and we had a relationship between the Pennsylvania College of Optometry and Hahnemann University. When I moved to Chicago to be the president of the Illinois College of Optometry, the chairman of the Department of Ophthalmology approached me, having read one of my papers on the whole concept, and asked if he could have one of these affiliations, as I remember his exact words. And we assembled the affiliation and had it in place by the time of my inauguration as the president.
That optometry is used differently now in the healthcare environment in Boston as a result of the college's efforts?
Absolutely. It's viewed, I believe, very much a part of the medical care, healthcare system where it was not before. These relationships have been invaluable in terms of furthering the profession's image in terms of its role in providing medical and health care.
What do you think the challenges are that optometry and the community health centers and community health are facing?
The challenges always boil down to financial support, both for the health centers from third-party reimbursement parties, and also to provide the continuing management structure that's necessary to sustain a diverse and complex set of affiliations that the college has.
Do you have any stories, Charlie?
Okay, I didn't really have a home base that I operated out of that was really significant. It was an office in Kenmore Square. And so it was necessary to stay in contact with the optometrists who were in the health centers. So in the absence of a conference room or an acceptable place to meet, every Friday after hours we met at Charlie's Saloon for our weekly discussions. And that continued for a number of years. And it's still remembered by some of the individuals that were in the earlier programs.
So it was kind of a happy time.
Well, I mean, we did conduct business, and but it was also, it built camaraderie amongst all of us. And I know that can be an issue, particularly now with such a large system, to maintain that camaraderie between those who are in administration, the college, and those who, quote, are in the health centers in the field.
Last thoughts, Charlie Burris?
No, other than it's always a pleasure to come back to Boston, interact with so many fine individuals in the NEI administration, New England Eye Institute administration, and the superb board members that the New England Eye Institute has. A very distinguished group, and they're a real pleasure to work with.
Okay. John, anything else you want to say?
No, I think I've said it all.
All right, great. All right, terrific.